right, if I could ask the speakers to come up, please. And we have about 10 minutes to take questions.
Thanks for the panel. Very interesting talk. I have two questions, maybe the entire panel, and the second question for Dr. Clift. First question is, you've shown that a lot of your patients, you start them with PDE5 inhibitors or pulmonary vasodilators. But also you do these elegant caths showing increase in the EDP pressure. How do you feel about these agents in the setting of rising wedge or EDP pressure? The second question is, for patients who are super Fontans, who are doing very well running marathons, anecdotally, we've noticed some of these patients have worse fibrosis, or we're surprised by the amount of fibrosis in their liver. Does anybody in the panel kind of see that in their practice as well?
So we consider the first bit. Because your circulation is running in series, the transpulmonary gradient will be the same, whatever the conditions, and EDP will reflect whatever stresses are going on within the circulation. So it will rise if there's at any of the points along the circulation there's a problem. It will also be very dependent on your hydration status at the time. So one of the reasons I'm not keen on doing routine catheterization is I'm not sure how easily you can compare two catheters side by side in a patient. So you may have somebody who's done on the beginning of the list and they're starved, but you've given them a bit of IV fluids, and then you do somebody later on the list who isn't. So those things are really important. And so part of the cardiac catheterization, I think the interpretation of the results depends on the fluid status of the patient. I think the EDP always reflects the overall resistances in the circulation, which can be high for a number of reasons. And then secondly, on your liver fibrosis, no idea why that's the case, but I'm pleased to hear there are other people doing that much athletic work.
So I'll comment on the first question and the second one. I think this is why I favor, one of the many reasons that I favor invasive catheterization for the assessment of these patients, because taking Dr. Clift's point, yes, there will be differences in the volume status depending on when you're doing it, how you're doing it, et cetera, and time of day. But I think it does give us valuable information, because if the univentricular EDP in a patient is 7 or 8 millimeters mercury, and you do have a slightly elevated transpulmonary gradient, that's a patient that I think would benefit significantly from the pulmonary vasodilators, and that's where we would use inhaled nitric oxide in the cath lab to just assess the effects of pulmonary vasodilation. How well can that be translated into the everyday world with a PDE5 inhibitor is anybody's guess. But that is an area where I think cardiac cath and the changing of the steady state in the cath lab can help us answer that question. Regarding the liver fibrosis, you're referring to, I think, the work that has been done by Grushin Veltman and others showing an increase in liver stiffness during exercise that could potentially be mitigated with things like inhaled prostacyclin, pulmonary vasodilators. I don't know what the long-term effect of that is, but I can tell you one thing, and I think a lot of us that have been seeing these patients for a long time have identified that there are those Fontan patients that seem to be doing really well later in life, and at least anecdotally it seems to be the exercisers. And so, yes, their livers may be stiffer, but they're not manifesting any of the clinical scenarios that we would see with cirrhosis. So I would say, at least anecdotally, the benefits of exercise seem to outweigh the theoretic concerns about increasing liver stiffness. But that's, again, in somewhat of a data-free zone.
Well, and also on the subject of exercise, if you look at all of the various interventional studies that have been done, there's usually a mixed pattern of results, but not with exercise. All the exercise studies have shown benefit for patients. The key thing with exercise is you improve your peripheral oxygen consumption, so therefore the requirements of the heart to deliver oxygen to the periphery is reduced. So therefore you're improving supply and reducing demand. It's a no-brainer. Exercise works for all cardiac conditions for that reason.
Thank you.
Just on this question of exercise, when I was at Yale from 77 to 82, we did a fairly large group of Fontans, and Bill Hellenbrand studied them in the cath lab with exercise. And about half of them had venous pressures that would go up from 14 to 20, but another smaller group were going up to 25 to 30. Now, if you're going to prescribe exercise to a patient and you're worried about a 20-year follow-up, surely it's important to know what happens when they exercise, because the one that goes up to 25 or 30 should probably be told that they should not do marathons and their exercise should be very light. And when you look at the patient who ends up needing a heart liver or gets liver cancer from their cirrhosis, it's worthwhile in the patient who will listen to you to prescribe lighter exercise and not to do marathons.
I don't think I'm prescribing marathons to anyone.
You know, one other thing to add to that, Laith, I think that it's a really important question, is the appreciation that we're developing for good mechanical pulmonary function, improving lung capacity, strengthening the diaphragm, strengthening the intercostal muscles in patients, and the positive effects that we get from that as far as suction within the Fontan circuit. And also the growing body of data suggesting that peripheral musculature can also help as small peripheral pumps for the Fontan circuit. So, you know, what kind of exercise, how much muscle bulking, etc. I think that is all something that we need to work out in the coming years. Patrick, please.
Hi, everyone. I'm Patrick. I have no formal medical training, so forgive the questioning, although I will say I've had some live fire training under Dr. A and Dr. Caldas.
So just to explain, Patrick and Lauren and their family recently lost a family member who had undergone a heart and liver transplantation a little over 3 years ago here at UCLA. She was near and dear to many of us, and I actually would like to say a word maybe when we come back from lunch, and her mother and stepfather will be here as well. But they have been intimately involved in the development of our Fontan survivorship program, and I think it says a lot when you have this kind of combination of care providers, family members, patients that are all involved together. We're all in the same boat together and trying to figure this out. So thank you for coming, Patrick. Thank you for coming, Lauren, for your support. Go ahead.
Of course. Thank you for having the symposium. So Dr. Small and Dr. Tan outlined steps taken to monitor the progression of liver disease in adult Fontan patients. And the title of Dr. Small's slide, Ultimate Destination of Heart-Liver Transplantation, it begs the question, are there other potential interventions that can mitigate the progression of liver disease that might be explored or be taken, that are not just assessing where the train is on the stops to ultimate heart-liver transplantation?
All right, that's a great question. We'll start with our panel. Dr. Clift?
It's a problem we struggle with as well. We do a whole set of investigations very similar to the ones that are done here, but predicting who's going to do well or not at transplantation has been a struggle for us. We had somebody die from liver failure post-transplantation, and we did all the tests we would do, and we're a liver transplant centre as well, and our team said, well, we don't think we would do that, so they sent them up to Newcastle, and they said, well, we probably would, and then the patient died. So it's really hard to understand it. Are there things that you can do to prevent liver dysfunction? I think no. I think the Fontan circulation per se leads to changes across the organs because of the circulatory effects of it. And there's building evidence to what's happening in the liver, which looks like it's on a cellular level, diffusion issues causing injury to the liver cells and leading to fibrosis. And I think that's an inevitability in the patients with the Fontan circulation. It's how we manage that, and happily people don't actually have overt liver failure yet. We don't know what the long-term outcomes of that will be, but I'd be interested if anyone has seen overt liver failure, because we haven't.
Just want to say something about, I think the inevitability of this is hard to grasp, but I think
prevention is really important, and Adam highlighted this too. And I think we can't really predict when the liver will fail, but there are a lot of things our patients and physicians can work on together to try to maybe mitigate these issues. And for example, alcohol intake and a lot of lifestyle choices, so high salt diets and things like that can really affect the life of the liver and maybe how healthy a Fontan patient can be for many years. So I think prevention is very important, and really counseling patients, taking the time to really tell the patients what healthy lifestyle really means, what it means for their Fontan longevity is important.
One of the things that has not been explored is the use of assist devices at the end stage. And there is one report of a patient who did very poorly after conversion, got a centrifugal pump, and then went on to get a permanently implantable heart-mate pump, and eventually went on to a transplant. So it is feasible, even with a single ventricle, to consider an LV assist device, and it's quite possible that if you have them on the assist device, that their liver will improve and their ascites decrease, which happened in this particular patient. There was a case report, and eventually may then have a heart instead of a heart liver. The heart liver is a huge operation. The results at UCLA we hear this afternoon are quite good, but there are not many centers that will have available a heart liver for these kind of patients.
I agree with everything that's been said. I will say this, that almost every time, with rare exceptions, that I take a Fontan patient to the cath lab for one of those routine catheterizations, we get information that gives us some degree of pause and changes our management. Simple example is you go in, you check Fontan pressures, and they're elevated. And in someone who has not been on diuretic therapy, and now you're putting them on diuretic therapy, or a slightly elevated transpulmonary gradient leading to PDE5 inhibitors. Or you do a liver biopsy, and you show that there's advanced bridging fibrosis, and it changes the way you're imaging them and how regularly, in order to look for things like hepatocellular carcinoma, where the risk goes up now because they have fibrosis. So, but you're right, they are small changes that we're making. We're basically changing the dials a little bit here and there. No massive changes that will alter the course completely, except for something as extreme as what Dr. Lax just brought up, which is a ventricular assist device to completely decompress the circuit and allow that liver to heal, and maybe allow for just a heart transplant alone in the long run. So it's a great question. Thank you for asking it. I think we'll take one more question from Dr. Wayne Franklin, and then we'll go to lunch.
Thanks. Wayne Franklin again from Phoenix Children's. Regarding the Fontan conversion, Dr. Lax, and I'd be happy to hear from some of the other panelists too, do you think the benefit is from the antiarrhythmic effect or from a hemodynamic improvement, or what are your thoughts?
There's no sort of clear-cut thing as to what causes this progressive ventricular deterioration in Fontan patients, and particularly the RA to PA. But it's very likely that the arrhythmias are much more prevalent than we see clinically, and that if you put implantable devices and looked at these patients, you would find that there is a lot of arrhythmia that's not being recognized, and that is gradually affecting the ventricular pressure. There's also the potential, which has never really been proven, is as to whether the high pressure in the coronary sinus causes ventricular impairment. But I think that because of the hemodynamic advantages of the conversion, that it should be done right away. And a lot of these studies, you can get an inferential conclusion that the patients do much better and their ventricles last longer after conversion than if you leave them with this huge right atrium and the potential for arrhythmias that are more frequent than we know.
So I was going to say, I think, in terms of Fontan conversion, the atrial arrhythmia surgery, I think, is obviously beneficial, and the modified RRMAs was studied by the Chicago group very early on, looking at just the simple, like Dr. Lack said, simple CTI lesions versus the more extensive RRMAs lesions, and they showed a big difference in arrhythmia recurrence. So I think the arrhythmia surgery obviously is going to play a huge role on arrhythmia recurrence after the surgery. And the other thing is atrial pacing. If you have pauses in your rhythm, promote reentry and ectopy. And so by suppressing bradycardia with pacing, I think those patients oftentimes do a lot better. So I think the combination of those two things is probably what affects the arrhythmia recurrence.
We probably have a slightly different approach in that we haven't routinely converted any patients. We've converted those who've either had thrombus in the right atrium or have had really difficult to control arrhythmias. And I think the major benefit has been with the arrhythmias. We've routinely done the extended maze when we've done it, and we've placed epicardial pacing. So we've always put one lead on the front, one on the back. So we've got synchronized pacing. And I have to say, in those patients that we've done it on, it's done very well, but we've had 1 out of 10 die. So, doing it routinely when you're quoting the 10% risk is a hard sell to somebody who's living a reasonable quality of life. And so that's why we haven't gone down as a routine pathway, and I accept entirely the comments that if you do it early, they do better, but still it's a 10% mortality, so we're reluctant to go down.
That's going to conclude our session.